Hello, everyone. We are live from the University of Miami Gordon Center for Research and Medical Education in Miami, Florida. And I'm really excited to be here with you today during Healthcare Simulation Week to talk about how we can use simulation to improve patient safety in hospitals. So we're going to go ahead and get started. So I just wanted to start with a little bit of history about the Gordon Center and then a little bit about myself. So first of all, the Gordon Center has been around since the late 1970s, focused on healthcare simulation. We are a center of excellence of the University of Miami Medical School, focused on medical education. And our mission is saving lives through simulation technology, but really our focus is not just simulation, but how do we leverage technology to help improve healthcare professions education. And we do this locally in our state, nationally, and also all over the world. It is also the home of Harvey, the cardiopulmonary patient simulator, and that is the way that we got our start. So Dr. Gordon, who the center is named after, invented Harvey back in the 1960s, and we got our start with simulation that way, but have been around for quite some time. A little bit about myself. So as you know, my name is Yvette Matola. I'm an emergency medicine physician by training. I had the wonderful opportunity to do all of my training in Boston, and towards the end of my residency is when simulation was really getting going within emergency medicine training, and I had the opportunity to work with Chuck Posner and Jim Gordon at the Harvard program, which was really a wonderful start. So I've been around simulation since that time, and I've been here at the Gordon Center for 11 years now, directing the pre-hospital emergency healthcare division, focus on all types of emergency medicine education, and I became the assistant director of the center 2 years ago now. My focus within simulation is, again, everything having to do with emergency medicine and response to critical events. I do quite a bit in the world of team training and interprofessional education, along with our nursing, physical therapy, and other colleagues. We also do quite a bit of faculty development, which is another area of interest for me, as more and more educators have been asked to incorporate simulation, and simulation has really taken off. How do we help them be as effective as possible in that role? And the last piece that I've always had an interest in and I've gotten quite involved in is in disaster response training. And we want to take a moment to think of our colleagues and other people in North Carolina and the Carolinas right now. And I understand there's actually tornadoes in part of the country due to the Hurricane Florence. So we in Florida are very familiar with hurricanes and all their aftermaths. So we're thinking of them and hope that everybody is safe. And if you're able to have digital connectivity in those areas and are joining us, a special welcome to all of you. But this is another area I'll talk about a little bit where leveraging simulation to help with disaster response training can be quite powerful. So just a moment to talk about questions. So we'd really like you to use the Q&A function in the Zoom application. So we're going to try to keep all the questions until the end, just because of in the interest of being able to do the presentation and the number of participants. We're also going to try to answer as many as possible, but we might put them in themes. So if there's several questions on the same theme or topic, I'll answer those in that way. And we may not get to all the questions. Laerdal has let me know that they do have a way, if you use the Q&A function, to let me know your questions afterwards, and I can also try to reach out to you and answer any questions after the fact if there's still lingering questions. So please use your Q&A function and not your chat function so that we have the ability to do all of that. There was one other question that already started at the beginning, and I want to just take a moment to answer that also, which is whether this will be available afterwards, and the answer to that is yes, through the Laerdal site. This will be recorded and will be available afterwards as well. The only other exception to questions at the end is if anyone has any questions or clarification related to a terminology that I've used or something on the slide that's not clear, please do go ahead and let us know, and I will try to answer that right away. We're going to start with a couple of questions so I get to know who's in the audience today. The first question is, what's your primary professional role? And I know, of course, that we all have many of them. So think about the context of this presentation and what's your main role. So it looks like the majority of you are in the educator faculty role, but we have quite a few in the SimTech operations, actually in every category, and a couple researchers out there, primarily role as researchers, and we have other. I'm interested to know who those folks are. Maybe if you want to put in the Q&A a couple of categories we may have missed. We try to be as general as possible to capture most of you. So that's wonderful. The next question is, where are you based for your primary job function? And again, these are catch-all categories, and probably most of us work in multiple of these areas, but where do you spend most of your time? And if you're based out of a sim center, I know that could be hospital-based or health professions school, but I specifically wanted to know which of you are actually at a sim center, regardless of where you are. Okay, great. And it looks like the majority are in the clinical setting. So that's wonderful, because that's what we're going to focus on today. And I know for those of us in sim centers or health professions school, we end up training folks in all these different areas, including the clinical setting. So it's applicable to everyone. So I'm going to talk a little bit about today, first, the incidence and prevalence of medical errors in healthcare systems. Obviously, we can do a lot in the context of clinically based simulation training, but I want to focus specifically on how do we improve our patient outcomes and reduce errors. I'm going to talk about how simulation in general and in-situ simulation, which I'll define a little bit further, specifically can be used to improve patient safety. And then we'll talk a little bit about what are the learning outcomes that can be taught utilizing in-situ simulation. We'll also talk about our experience, and I picked one example that has been sustained and robust with a hospital-based quality improvement program using simulation. And then we'll talk a little bit about the benefits and challenges of in-situ simulation and how to overcome them, or at least think about them. So what is patient safety? In its simplest form, it's freedom from any accidental injury while receiving healthcare services. And we can talk and think about what are the most common areas where this happens. And there's been quite a bit now looked at and studied on this related to either communication or procedures, medication errors, et cetera. There's quite a bit of a list. We work in very complex systems, and so the opportunity for error is high, and this is one of the ways that I think we can leverage training and simulation to try to mitigate and reduce that, just about anything that's preventable. And we've already become very aware of this and instituted systems based responses to this with checklists and double checking and timeouts in this over the last decade, as we became more and more aware of the impact that this had on morbidity and mortality. So most of you are probably familiar with this report that came out in 1999 from the Institute of Medicine, and it's when we really sort of woke up to the quantification of how many people are dying due to medical errors. And there's been quite a bit published since then. A recent report out of Johns Hopkins talked about 250,000 perhaps medical errors annually. So not all of those result in death, but result in either some kind of negative outcome for the patient or just occur in whether or not there's a negative outcome. And so again, this is an area where we have an opportunity to make a huge impact with training and simulation. So medication errors are the leading cause of all of these errors, with surgical mistakes and complications being the close second. And of course, within those categories, there are additional reasons that this happens, right? So again, I talked about communication, familiarity with equipment, orientation, some of these things. And the Joint Commission has done some work in actually looking at what are the most common causes of this. And about 7% of hospitalized patients experience a serious medication error. So yeah, these are US statistics. Somebody just asked about the Institute of Medicine is focused on the US. So these are United States statistics. Thank you for that question. So if we look throughout the world, the numbers would be even higher. And I think one of the big takeaways from this is that as we look, and we've learned a lot in simulation from other professions that are high risk, things like aviation, nuclear power plants, space travel, et cetera. We've learned a lot from them on how to really train and develop systems of safety that help reduce error. And that's, of course, applicable to all. So simulation-based education often occurs separate from the clinical context, not always. And again, we've been doing more and more in clinical-based simulation in either simulation centers, such as, which are termed offsite simulation, just to clarify a couple of terms. But on-site simulation, meaning clinically based simulation, can happen in the hospital and not be really truly in situ. So when we're talking about in situ, and what I'm going to focus more on today is when it's really in the clinical context. So not just that it happens at a hospital, but that it happens, or a clinic, but that it happens in the clinical setting, whatever that is for your learner audience, with all of the systems, equipment that they would normally be working in. So it's all of the components that they would be working on. And of course, we try to recreate this quite a bit in the simulation lab, and we do a very good job of doing this, but there's something lacking to truly recreate the entire environment that taking simulation into the clinical environment allows us to do. And so although we can do individual and team training in the sim lab, we can't recreate the entire complexity of the clinical hospital setting. So taking the simulation to that setting is really powerful. So situated or in situ simulation, or ISS, and that's not the International Space Station for other space buffs like myself, but ISS in this context, which is in situ simulation, describes simulation-based activities that take place in the actual context, like I just said, where the clinical care is being provided. And there was a nice article by Spur and colleagues that looked at sort of what are the 10 ingredients to try to make this successful. And again, we can do things like train for rare events. And one of the other things that is incredibly powerful, and in my experience with this in the program I'm going to talk to you about, I think is one of the incredible outcomes and rewards that comes out of this, is that you're able to identify these latent safety threats, which I'm going to talk a little bit more and define, and other systems issues that really don't happen as much when you're in the sim lab. So when you run these simulations in the clinical setting, all of the things that work or don't work for the healthcare team actually are uncovered, and you can really see them, identify them, and ideally help rectify them. So here's another question for all of you. Does your hospital or clinical organization currently incorporate simulation? Okay, so the majority of folks are in the yes, but it could be optimized category, which is not surprising. I think that's probably true for the majority of folks, and some of you do have robust programs already, which is wonderful, and others are considering implementing, and hopefully this will, I hope this serves to be your kickoff to get it going. But absolutely, and I think most places really are underutilizing simulation as a training tool in the clinical setting for all the reasons that are kind of obvious, and I'll talk about some of them. But we can definitely optimize and utilize simulation significantly more than we are in the clinical setting. So that's one of my hopes and goals that come out of this today. So some of you may have seen this by Roger Kneebone from the UK, thinking about what's sort of the optimal way to use simulation in our educational and professional contexts. And if you look at this at the top, the learning needs are often identified in the clinical setting. Of course, if you're at a health profession school, you may already have a set of learning outcomes that you have to teach, and that's also part of the learning need. But if you're talking about experienced providers or even trainees that are now in the clinical setting, we can figure out a lot of what's needed from what's happening on a daily basis. And I'll talk a little bit about quality improvement and patient safety in that context. But training needs become obvious from that setting. And then we take those and turn it into simulation-based practice. And again, I think historically that happened a lot in the simulated environments that maybe were separate from the clinical setting, or maybe part of the clinical setting but aren't truly in situ. And then once that practices happen, hopefully the practitioners take whatever they've learned back and reapply the skill. And with that, we then review and have further practices needed. And this is a continuous cyclical process to try to continue to improve our skills. Okay, someone asked if there's a Spanish translation service for the webinar. We do not have that for this webinar. I have done this in Spanish in the past, so I'm sorry we don't have it for this specific webinar, but I will see if we can do one in the future in Spanish for our Latin America and other Spanish-speaking colleagues in the audience. So, so sorry, not for this one. So what we're talking about today is taking that simulation-based practice and putting it directly into the clinical setting, such that we now are, again, this whole idea of recreating the environment or taking people out of their clinical setting to do this practice, we put it into the clinical environment. And this is a little bit of an example of what it looks like, and I'll show you some more pictures of our experience. But learning is a function of not just the activity that we put folks through, but also the context and the social culture in which it occurs. And I think, you know, maybe in healthcare more than anywhere, you know, it's great to do things in our controlled conditions in the sim lab, but it's also really powerful to take it into, you know, the real world, right? To take it into that clinical context where a bunch of other learning opportunities come that we don't necessarily have in the sim lab. So I wanted to show an example, and this is a video courtesy of Wiser that we use in our simulation faculty development course called ISIM. And I wanted to show this one because it's a really nicely staged video of what it can look like. And just to orient everyone, this is obviously a pediatric mannequin. The context is the pediatric intensive care unit, and this mannequin is on ECMO when something starts to happen. So we're gonna go ahead and play this for a minute.
What you can?
No. That's a big red pen.
Lose a return. I'm gonna turn the floor down.
I need some help in here. What can I be getting? I need a doctor. I think the cannula's out.
It is up. It is up. Neck clamp. All right.
She be cannulated? Yeah. We need more hands. Could you give me an RT?
We're gonna come off bypass.
Okay.
You guys need some help?
Start bagging, please. Okay. Yeah, could you please draw 60
Pumps off.
of normal saline and also some blood?
I'll take the
I'm not
blood.
getting any flow in my bag. Is it hooked up? Is it hooked to the wall? Oh, she's on nitric. She's on nitric. Switch to nitric, yeah. Blood pressure is 54/28. It's set to 72. You're moving her chest pretty well. There's a lot of blood here. You ready to get in with William?
I'm gonna transfuse up the venous line.
Okay, you've got an open line here on port 1. Once you hook that up, could you try to start making up an epi-drip?
You don't use the emergency settings on the ventilator?
Yeah. Right? So rate of 30, keep it 10, 100% oxygen.
Okay.
And nitric at 20.
Got it. You can put the patient back on the vent.
Still bleeding.
Pause it.
Okay.
So I wanted to show this as one example, but one of the wonderful things that happens when you take the simulation into the actual clinical setting. So looking at this frame right on the screen, you know, recreating all the complexity of, say, an ICU, but even a regular patient room or other areas of the hospital, the OR, the operating room, et cetera. Again, we can do quite a bit in the simulation lab, and we've done an amazing job of that. But you can see that it's so much more powerful to do it in the clinical setting with all of the actual equipment, with all of the personnel. So you think about other people that we may not necessarily bring into the simulation lab regularly in the healthcare team that you can incorporate into the clinical-based simulations. such as additional techs or the unit secretary that may have to order something or make a phone call or activate a system, security, all of these folks that are involved in our complex healthcare system that we don't necessarily bring into the sim lab. There's so much focus on specific disciplines. We can have all of this. And again, we're going to talk about some of the challenges related to doing it when people are working clinically, but we can do this within the clinical setting and get everyone while they're actually there. So what are some of the things that can be taught? And quite a bit has been written about this. I've chosen just a few articles to elucidate, some of what's out there. But lots of different skills can be taught. So obviously, I think one of the most powerful places is in the context of team training and crisis resource management, which we'll talk about. You can obviously teach individual skills, and there's some nice articles that have shown programs related to rare procedures or other individual skills that are brought into the clinical setting after training in the sim lab. And things like training on equipment or figuring out how equipment is working, and doing that in the actual clinical setting can be quite powerful. Processes, systems, and orientation to new spaces are other opportunities for clinical-based sim. We can also use it for testing. So we can use it to assess learners and assess systems. Of course, in this case, our learners are healthcare providers and the whole team. So we can use it for assessment. And really here, we're talking about formative assessment. Although I have worked with some nursing colleagues that are really trying to use this as some of the summative assessment before someone is checked off to be able to perform a skill or use a specific piece of equipment. But most of what we use it for is informative assessment to give feedback based on what we find when we assess. Also for testing new equipment, spaces, or processes. This has become quite common where simulation is being used to assess new facilities, or even in the design and planning of new facilities or new areas to determine where is the best place to put certain things, equipment, monitoring, etc. So there's quite a bit of opportunities related to simulation in that context. And then who can be taught? And I think, in addition to the equipment and the environment fidelity piece, this is a big area where it can be quite powerful. And we especially know that once our healthcare providers are working clinically on a regular basis, getting them into the sim lab can be quite challenging just because of busy clinical schedules. And of course, our main focus is patient care. But even with our trainees, it can sometimes be challenging. So the entire healthcare team can be taught in the context of in-situ simulation in the clinical setting. So everyone from our nurses and physicians to respiratory therapists, pharmacies, trainees at all levels, technicians, so not just radiology technicians, but other kinds of technicians that may be involved. If you have paramedics that work in your area, other types of technicians depending on the area that you work in. Like I said, unit secretaries, security, we incorporate them all into this if it's an appropriate part of the simulation scenarios. So it really includes the entire healthcare team, including those that wouldn't normally come to a simulation center. So how can we use in-situ sim for quality improvement? So crisis resource management in teams is, I think, one of the places that it's used most commonly. It's definitely where we've used it most commonly. Of course, I'm an emergency medicine doc, so this is a big area of focus for me, is helping people and teams be as effective as they can be in responding to a crisis situation. Latent safety threats. So these are not only uncovered when you do these, but also an opportunity to fix them comes up, and that's hopefully what comes out of this. And other systems issues as well often come up. Rare procedures, again, things like cricothyrotomy and other rare procedures that you could think of, LVAD failures, et cetera, that may come up that our healthcare providers aren't having an opportunity to practice on any kind of regular basis. But then when it happens, you really have to be able to respond quickly and efficiently and effectively. Assessing adherence to guidelines. So folks have used this to go around and either run mock codes where they're actually running resuscitations, or other kinds of programs looking at whether people are adhering to guidelines such as sepsis guidelines or febrile neutropenia guidelines, Resuscitation is obviously the one that comes up quite commonly, but there's many others in obstetrics and gynecology, et cetera. You can think about many opportunities there to assess whether folks are really adhering to guidelines, and then bridge any gaps that are found related to that. I talked already about testing new facilities prior to opening, and there's been a few descriptions of this in the literature. And then disaster response and mass casualty incidents. So again, these are times when our healthcare systems and healthcare providers are really stretched and taxed, and getting to practice that and figuring out what is working, what's not, what needs to be changed is so important, as we've learned so much in our state of Florida with not just natural disasters, but also the human-generated disasters that we've dealt with, or mass casualty incidents that we've dealt with quite often recently in the context of active shooters in different areas of our state, and all of the different hospitals and clinical systems and EMS that have had to respond to that. How do you do that effectively? And so again, the best way to really assess that and give people an opportunity to practice is to do in situ simulations related to that. So here's an example of what crisis resource management looks like. Again, this is when we're talking about some kind of crisis occurring. And often people think about resuscitations or codes in this context, but of course, the vast majority of our crises are not really the codes and resuscitations. There's just deteriorating patients or something else that's happening. Folks have done fires in the operating room, or things of that nature. But the idea is that it gives an opportunity to review how to most effectively respond to these, and how teams can work really effectively. And again, invariably, you're going to uncover systems issues or latent safety threats that need to be addressed when you do this in the clinical setting. So I've talked about this a couple of times. I wanted to make sure it was sort of clear to everybody and show a couple of examples what latent safety threats are. And in their simplest form, it's accidents waiting to happen. We've definitely now have quite a few articles out in the literature that have shown that multidisciplinary in situ simulation can identify latent safety threats and improve patient safety, because what you want to do once you've identified these, obviously, is address them. And this is an example by Wheeler et al. Showing, and there's again a few in the literature, and we will make available the reference list, which is not completely exhaustive, but has quite a few references for you to be able to follow up with some of the things that folks have done related to in situ sim in clinical settings. But looking at this, this is examples of latent safety threats and opportunities for improvement that they identified by a series of in situ simulations. And you can look, there's medication, there's equipment, and there's resource systems issues that were uncovered that needed to be fixed. And these happen pretty much every time you run an in situ simulation in the clinical setting. The program I'm going to talk about, we've been doing it now for over 5 years, and still, when we run a different kind of scenario or in a different area, something comes up that can be improved. And so it's really a wonderful opportunity to uncover these and address these, because at the end of the day, we want our healthcare providers to be set up for success, right? So that we have the best patient outcomes. The other thing, if you look under resource system on this slide, is that the other thing that's invariably uncovered is the need for additional training. And of course, and we have to convince everyone that we have to do this training, but things like ACLS training in the context of resuscitation often comes up as something that needs refreshing or more training. Crew resource management, again, the teamwork characteristics that make and help teams be effective in a crisis, the communication, the clear leadership, followership, shared mental models, all of those things are skills that can be taught and practiced, and in situ simulation often uncovers that we need more training in this, and then also gives an opportunity for training. But invariably all of these things come up. So we're going to ask another question here of all of you. Do you or your organization utilize simulation to address patient safety issues? So that's great. So the majority do, and that's wonderful to hear. And again, I think this is an area that just has been growing exponentially, because for all of us that have participated or have run these programs, you really see the impact and the potential to improve this. And as I said, as we focus more on improving patient safety, I think we all feel like, you know, that the right number of errors are zero, and we need to do everything possible to get as close to that as possible. So if you don't, this is a definite opportunity to do this. And I'll talk a little bit about where you get the ideas of content, which is of course a clinical setting, how we approach this. So I wanted to spend a little bit of time talking about one of the programs that we set up with a visionary institution that not only self-identified the need for this kind of training, but has also been able to sustain it for a few years. And that's a challenge, because often what happens is something happens that's a negative outcome, and the organization wants to invest in this, but then it's not sustained. And of course, for these things to really be successful long-term, it has to not just be started, but also be sustained. So the example that I'm going to talk about is in conjunction with the Bascom-Palmer Eye Institute, and I'll give a little bit of background. But it's a combination of first 5 minutes and rapid response team training plus in-situ simulation for improving response to emergencies. And they themselves identified that they had an issue with response to emergencies and wanted to use training and simulation to bridge that. So a little bit of background about Bascom-Palmer. It has been the #1 eye hospital for 17 years. And like I said, they identified a need for training and response to emergencies. It's a little bit unique because it's not a full acute care medical surgical hospital. It's truly functions more like an outpatient and surgical center. They do have some inpatients, but it's usually, you know, overnight observation of surgeries, of surgical patients for one night, things of that nature. But the volume of people that come through there, both for their outpatient clinics and for surgeries, is quite high. And of course, when you think about who are the folks that are needing these surgeries, there's a huge range of patients with a lot of comorbidities, like diabetes, like cancer. They also do a lot of ear, nose, and throat surgeries, from your usual tonsillectomy and tympanostomy tubes to more complex surgeries. And they also do some orthopedic surgeries like hand and microvascular and those kinds of things. So there's a big range of patients that come for care there. So emergencies are not well, I don't want to say not very common. They're common, but they're not happening all the time, because again, you don't have intensive care units. You don't have the sickest patients. These are usually ambulatory patients that are coming in for something. But of course, like I said, because of the substrate that these patients come in with related to comorbidities, the opportunities for emergencies are high. So they came to us and asked for help with training to try to improve their response to emergencies. So we started with a combination of things, and we've continued this. So we hold annual training, and I wish we could do it even more often, but every year we bring to the Sim Center the rapid response team members, and we use rapid cycle deliberate practice to train on I'll talk a little bit about the scenario choice, but to do a didactic session. Again, that didactic session is really focused primarily on crisis resource management skills, teamwork skills, and so we'll review the things that are have been shown to be effective related to response to crises and working together as a team. And then we immediately go into simulation scenarios with debriefing. We usually will put them through several simulation scenarios with debriefing right afterwards. And we pick the simulation scenarios, again, just like we do for our quarterly events in situ. We pick them with the healthcare team that's there. So the nurse educators, the nurse managers, and the other folks that are involved, the rapid response team leadership themselves. And they help us identify what are the areas they want to focus on based on what they've been seeing or they think their personnel need practice with. So then in situ, we do two other things. So we bring the rapid response team to the clinical setting. And by the way, we do this on Saturdays because these are all busy clinicians, and during the week at this high volume surgical and outpatient clinical setting is really challenging. So we come in on the weekend to do this training for them. And then we do two things in situ. So one is a first 5-minute training, and all of the nurses along with The unit secretaries are involved in this as well, go through first 5-minute training. And again, this is focused on those first 5 minutes before the rapid response team is able to arrive, on what it is that they need to do to both assess and manage the patient, and also activate the systems that are going to help them in helping take care of the patient. And so this, again, is a combination of a little bit of didactics. We usually review some of the BLS components as well, again, just to go over those since they're not using them on a regular basis, and give them some CPR practice, as well as some other kinds of things such as EpiPens and things are, finger stick blood glucose, any of the things that are commonly or may commonly happen. We review those, and then they go through simulation scenario in that setting. And then we do quarterly, what I like to call simulated critical care events. Everyone still refers to them as mock codes, but most of the cases that we do are not full resuscitations, so I don't like to call them codes. And again, we do these, and I'll go over a little bit how we do them within the hospital, but we do these quarterly to, again, maintain the training, and we'll talk about how these have uncovered some of these latent safety threats and systems issues. For each event that we run, so for each simulation, we look at the clinical management of the case that's presented to them, and then we look at teamwork and systems as well. And I'm going to show you a couple of our checklists to look at how we do this. And then we debrief. And so we debrief the team that participated. We try to keep everybody there. Again, everyone that responded, including security and other healthcare personnel that were involved, and we debrief everyone on these 3 areas. And the picture on this slide right here actually shows another area that I didn't talk about. So they also have a sleep center there. And so one of the cases that we did there was post-sleep study MI, where the patient wakes up with chest pain, and they have it's a 10-minute scenario. With 5 minutes, they have to manage their myocardial infarction, and then the patient actually goes into VFib arrest. And so now they have to figure out the patient's on the soft bed because they sleep on regular beds. Now we have to do CPR. So figuring out how we either get, the board underneath the patient, or maybe move the patient to the floor if that's not available. However it is, again, all the things that they're likely to be challenged with actually happen. So it's an ongoing process. So I regularly meet with the patient safety, quality improvement, and rapid response team committees to determine what's working, what's not, what are the areas that they may be having issues with. And so based on those meetings, we determine the needed areas, so what are the next scenarios that we're going to need to focus on? Is it seizures and MI? Hypoglycemia is a common one there because of all the patients that are NPO haven't eaten for their surgeries, and there's a lot of diabetics. We recently did malignant hyperthermia with them because they had a case of that. Again, rare event where your systems really need to work well to take care of the patient in that context. And then we developed the simulation scenarios and checklists related to that. We conduct the training with debriefing, and then we report back to the hospital with a summary. And then not only do we talk about what went well and opportunities for improvement, we also give them feedback on any latent safety threats and systems improvements that are needed based on this, and any additional needed training. Oh, okay. So someone asked a question, and we could have maybe answered it then. But so do we give a warning? And I'll talk a little bit more about this. So there has been some written in the literature. Do we let them know ahead of time? So for our program, we do not. Everyone knows because all of the nurses and ARNPs and the physicians that are in house all know that this is a program that we're doing on a regular basis. They've all come to the sim lab for training, but we don't let the nurse managers know. And the educators know, but we don't let everybody else know that this is the day we're doing this. There's varying thoughts on this. I think it's okay to let people know. Obviously, you have to set up the space and pick a time that works for all of the staff, which is one of the things I'm going to talk about. So there has to be a collaborative effort, but we don't usually let the providers know that this is happening because we want it to be as realistic as possible. And if someone starts to deteriorate or has an event, they're not going to be told, at this time on this day, this is going to happen, right? So this is what, and I know these are a little bit small, so it's not totally easy to see, but I just wanted to show you an example of what we look at. So we look at teamwork, and again, this checklist is adapted from the team steps components and some other. So it's sort of we've pulled out some of the components from other teamwork type checklists. And then we have one that looks at the systems evaluation. And when you look at that, we're really looking at times of arrival, when resources and equipment get to the patient. So does the crash cart get to the patient in a reasonable time? Is the rapid response team activated? For them, it's very specific. They have to activate 911 because it's not an acute care medical surgical hospital. So if somebody needs additional level of care, they actually have to transport them out. So in that sense, it functions as an outpatient clinic. So when does 911 get activated? Because of course there's going to be some time until EMS arrives. And so we want them to do that as soon as possible when they've identified it's needed. And then we look at the actual clinical management piece. And so the checklist on the right is one of the scenarios where we do pediatric asthma, that again, about 5 minutes into the scenario, the patient goes into respiratory arrest. And again, we give them that just to give additional experience and practice with a patient in respiratory arrest. But the asthma is more likely what they're going to encounter. And so here, this is just a snapshot of the tracking of cases. We've done a lot more because we've been doing this now for a few years. When we initially started, we were doing 5 areas in one day, and we stopped doing that for a couple of reasons. One was obviously by the time you're on case number 3 or 4, everybody knows in the hospital because the rapid response team has been activated an inordinate number of times. And 2, it's super exhausting for us, and also just to capture all of the information and give it back to the hospital. So we initially did many, and then we backed off to 1, and we've sort of, I think, hit the sweet spot that when we do these, we pick 2 areas. We do two scenarios, and we use both simulators and standardized patients. We do these in common areas, and I'll show you a couple of examples of that, because again, some of these emergencies aren't just happening in the patient care area. They can be happening in the lobby. They can be happening in the cafeteria. So we really go through all the different areas. And of course, the tracking is really important because it shows you what you've done in each of the clinical areas, and it shows you what you've done as far as the clinical scenarios themselves, so that you can challenge them with different things and make sure that you're hitting all the areas. But I just wanted to show you an example of what that looked like. And here's some of the examples and pictures. So on the left, it's their emergency department. And so they have an ophthalmology emergency department there. And that's a baby pediatric seizure. We've done them at all different ages where they had to manage it. And again, figure out how they're gonna get the patient from the waiting room to the patient care room, activating 911, managing all of that kind of stuff. The one on the right is the ambulatory clinic waiting room. So you see they have the baby on the floor because there's really just chairs around. There isn't a stretcher or a bed readily available. And that one is a pediatric respiratory arrest scenario. This one is actually looking at the operating room. So we've taken these into the OR in all the different areas. So pre-op, post-op, and intra-op. And the one on the left there is setting up for an MIV fib scenario in the post-op area. Cement 3G there is holding his own computer, but we have to all get dressed. Talking about logistics, we all have to get dressed in OR garb in order to go in and do this in that area. And then the one on the right is the malignant hyperthermia scenario, which we did a few times to get all of the surgical staff access and practice with this, because like I said, they had a case that occurred and developed over the surgery on the slower side, but it really uncovered the need for training in this area. Again, rare event, high impact, you need to be thinking about it, and then you need to be able to institute all of the systems that are going to help treat that patient successfully. So what are some of the latent safety threats that we've identified, and also systems issues that we've identified in doing this? I've excerpted some. Like I said, every time we do it, we find new ones that we can then address. So one of the biggest ones that we found initially when we first started doing this was the location and familiarity with crash carts. Again, these crash carts are not used very often in the setting that's mostly outpatient. Then we also found that from a logistics standpoint, the crash carts were behind locked doors in the majority of areas with limited access, because the person that was responsible for them was worried that a patient or someone would come by and try to take something off it or open it, and so they weren't in readily accessible areas. So we worked with them to obviously address that. That was a low-hanging fruit that needed to clearly be fixed. One of the things that we also realized was the availability of pediatric equipment. And so we helped them set up a pediatric box with all the PD equipment that's needed. When we ran our last scenario, which was actually last week, we found that another issue that's come up is where this equipment now lives. So it's living in the pediatric areas, which makes a lot of sense, but it's actually hard to get to certain areas, and it's not with the crash cart. So we've told them you really need redundancy of also putting these with crash carts now, so that it can come when there's a response needed. We also learned that accessing benzodiazepines in a timely manner for seizure was a problem, because it doesn't live in the crash cart, because what they're utilizing had to be refrigerated. So, how do we help them work around that? Maybe they switch to a different agent that they can put in the crash cart. We again identified, which is a common theme, that there was training needed in BLS and ACLS. When we first started this, they were doing outside training, and we now help them with all of their BLS and ACLS training to make sure that it's robust. And obviously doing things like RQI or continuous training in this area is so important, because they're just not using it very often. And so those skills decay quite quickly. And then things like ability to provide medications and check blood glucose for visitors came up pretty early on also. They relied on the patient identification bands, and then we found, well, what if it's a visitor, right? A lot of the responses end up being not necessarily the patients, but the visitors. Are we able to check, or before the patient's checked in, are we able to check their finger stick? And so they developed a system where there's a rapid response team scan for all of these things related to giving medications until the visitor actually becomes a patient, or the patient is checked into the system. And a commonly encountered area too was just a familiarity of staff with the process for calling rapid response team. When should they call? How do they call? And activating 911. Okay, sorry, I just saw that there was a question related to explaining what mock codes were, and I'll actually just hold into the end, because we're close to finishing here, and I'll address that one first. So what we've seen over the 5 years is a significant improvement in patient outcomes and safety. Like I said, there's no perfection. There's still room for improvement. Every time that we do these, we find that there's other things that we can work on. But it's been really quite impressive to see the dramatic improvement. If I think back to when we first started this program to now, in their time to response, in the equipment, what they have access to, how quickly it gets to the patient, what medications they have, the process improvements related to this. We still intermittently will find something like there's the old guidelines book for the AHA guidelines is in one of the carts, so we immediately take that and replace it. So there's still things that come up. Teamwork and crisis resource management. This was not a language that healthcare providers in this organization, and as in many organizations, were really using before we started this program, because many of them had not ever been trained with simulation and had never been trained in these specific areas. And so there's been a huge improvement in teamwork, crisis resource management, such that now when we do the training, everyone's speaking that same language. And it helps us debrief and get learning from it. Medical management, again, of the commonly and rare things that they see, we've obviously seen improvement in those areas. And I think one of the other really super powerful things that have come out of this that I love is that they've taken what we do in the in-situ SIMS and adapted that for debriefing after real events. So the rapid response team now does this after every single event. They have a form that they use to evaluate and document what happened, but then they actually look at these 3 areas. So what went well and what can be improved in the context of the clinical management of the case, the systems response and any systems issues that arose, and then the teamwork components. And so they do this regularly. So again, what started as something that we just do quarterly, there's really learning going on and improvement going on all the time because it's happening after real events. And of course, this is a hot topic area in simulation. A lot of places are doing it, and I think those that aren't are seeing the value in doing it. Definitely as an emergency medicine physician, we really want to see folks do that after crisis events or after things go either really well or not so well to help improve. So the benefits, so again, the realism of doing it in the actual clinical setting is huge. The ease of access for busy clinicians cannot be overstated. Again, getting these folks out to the sim lab is really hard, and doing it in their area when they're there works really well. It incorporates actual equipment, personnel, and systems. Again, has multiple uses related to learning outcomes that you can teach. It integrates well with simulations in the sim center. So again, neither one of these things need to be standalone. Our program where we bring them to the sim center and do training here, and then do the quarterly in-situ events are really is a really robust way to do it, of going back and forth, and of course ultimately improves patient safety. So what are some of the challenges? So space is always a challenge, just like it is for simulation centers themselves, but finding the clinical space to do this in, and then finding a reasonable place to debrief. We usually try to find an area, whether it's either a patient room or if it's going to be a common area, we try to cordon off an area where we can have a conversation, and then always have somebody to let other visitors and patients know that this is a simulation, so that they don't, freak out or react to what's going on as they see the pediatric mannequin or they see a lot of providers around the patient. So you have to plan for that for sure. If you're based out of a sim lab and you're not based in the clinical entity itself, the clinical organization, how do you get the simulators there? So we use all kinds of different methods. We have a truck and a van, but we also recently acquired the golf cart that you see in this picture, and that's me taking a mannequin over to one of the hospitals to do some in-situ training. Again, healthcare providers' time. So taking the time away from patient care, even when doing it in the clinical setting, can be challenging. So working with the unit managers, the nurse managers, the residency directors, the clinical directors, whoever it is, to figure out what are the best times to do this, where there's less impact on patient care, or we often do this quite early, so 6 in the morning or 7 in the morning, to capture the overnight folks, or before the OR really gets started, or just because it's less busy at those times. So we as the simulation educators kind of have to be flexible with when we do these things to give folks the best opportunity for training. And then I think the other challenge is the investment and sustainment from organizational leadership. I think there's more and more in return on investment for these programs that have been shown and that exist in the literature, but you have to get buy-in from them, because of course it takes time, money, personnel away from patient care, and all of those kinds of things. But it's so much more powerful than the other types of continuing education and patient safety trainings that we've done. So I just wanted to take a moment to thank Laerdal Medical for hosting this. Also Bascom Palmer leadership and education teams and all of the providers that participate in this. I can tell you every time I go there, because my family member needs care there, or I'm just going for a meeting, everyone's always running away now. So there is a downside to that, but they've really been great, and everyone has embraced this from healthcare providers through leadership because they see the impact that it's had. Dr. Eisenberg, our center director, and then of course our team of instructors, Simtex, and staff, with which we couldn't get any of these things done if we didn't have such an amazing team. Again, it is Healthcare Simulation Week, so I wanted to say yay to everyone out there that does simulation, and make sure that you continue to simulate. We're going to do questions right now, and try to do these again in a systematic, themed way. But I wanted to start with one that was asked previously, which is, what are mock codes? So this is a term that's come out, mock meaning not real, right? So of course we use simulation to also mean that. And codes is because a lot of these historically were resuscitation type events, and if you were trained even before simulation took off so robustly as it has in the last 10 to 15 years, you know, you would often have this event where they maybe bring a resuscitation or some other mannequin into the clinical setting, and you would practice a resuscitation. And so that's where the word mock codes came from. So like I said, I like to call it simulated critical care events or critical events because you know, we're often not doing necessarily resuscitations. And again, the content can be from any identified either near misses or patient errors that did occur, or, you know, if you talk to either the healthcare practitioners themselves, nurse managers, they're seeing areas where there may be deficiencies or opportunities for training. So all of those are content areas for your simulation scenarios and what you want to do. Again, a lot of what we've done is in response to something happening, and they said, well, that wasn't really optimal, or it's an opportunity to train other providers that may have to face those situations. Okay, so there's a lot of different questions here. So let's start with, you can go ahead, Richard. Let's go ahead and start with the emergency response team, and do they have clearly defined team roles? So the rapid, it depends on which of the clinical organizations. I focus on Bascom Palmer, but we work with several of the hospitals, and they have slightly different structures. One of the things that I highly recommend is that they have a huddle at the beginning of the day and determine team roles ahead of time. The reality is that it's a little bit different depending on the time of day for Bascom Palmer, how many people they have, and who's going to take what role. During the day, they have the physician that's doing pre-ops, as well as an ARNP that are part of the rapid response team, and then a couple of nurses. At night, it turns out that it's the ophthalmology first-year resident. They're actually second-year residents, so they finished an internship, and they along with the ARNP, are the senior folks in the house related to leading the team. But generally, they do have specific roles related to getting equipment, managing the crash cart, documentation, all of the things that you would think are needed in a crisis response. And I'm going to answer the question on how do you engage physicians in simulation, because this is definitely an area of challenge in this particular organization. I've had less of an issue in our acute care hospitals, and I think the reason that it's an issue is because they're ophthalmologists, and a lot of them don't really want to get involved with emergencies. They don't feel like that's their area of skills, and so we've had to work with, and also sometimes around that to get practice. So I focused on the people that are actually going to be part of the response, and then we've made sure that everyone has those first 5 minutes basic level information. But really for this program, it's been the nurses and ARNPs, and then the folks that are the physicians on the rapid response team that have been most engaged in all of this training. But the way that you get them engaged is not giving them an option when you do in-situ. If they're there, they're part of the experience. And I think I didn't spend a lot of time talking about the importance of debriefing and setting up a safe environment. There's quite a bit in the literature on this as well. But I think the way that you approach it, I always like to have conversations and set the stage before I debrief, again, because these events are surprises. Again, we're there to help them be better at doing their job and to support them in doing their job. And I think if you operate from that perspective, and then you have your conversations and really as a coach helping them get better at what they're doing, with what went well and then the opportunities for improvement, most people are really open to that and are willing to participate again. Our experience has been that most people, once they participate, are really engaged, because, you know, if you think about what we do, especially in the world of continuing education, you know, they feel like we're spending time to really help them improve, and everyone wants to be better and as good as they can be as healthcare providers. I had a question about whether we would share checklists. Sure, we can do that. We'll connect with Laerdal and make that available along with the reference list. And then how often do we suggest these events occur for acute care hospitals? Well, if it was up to me, you know, every other day. You know, I think you have to work with your organization to see what's feasible and possible. Again, you want to capture as many of your healthcare providers as possible. So I think having that combination of the formalized regular training in the sim lab or at the hospital with the regular in-situ events are a great way to try to capture everybody. So you really want to make sure you do that, because if you only train, I mean, obviously training some percentage is better than none, but you want to try to capture as many as possible. So somebody asked about advice for developing countries that are resource constrained, and poor patient doctors are overloaded. Yeah, I don't know that it's hugely better here. I mean, I think we have better resources, but definitely, we never have all the personnel we want. That's a challenge, and I think you have to, looking at what's available to you. This doesn't have to be with the most expensive simulators. And I know even the simulation companies industry has developed some low cost options. And of course, people are really creative and develop their own as well for that part of the cost. But there's opportunities within every system, and we have worked internationally with some resource poor areas and still are able to do this kind of training. Again, you have to figure out what are your best times that you can do this to really get people engaged and do it. But it's something that can be done with any level of resources, depending on what you have access to. And then, do we have data publications on patient outcomes? So, there are a few articles on this out there related to these type of programs. We ourselves do not, because our focus has really been the healthcare providers, but it's one of the things I've been asking, especially Bascom Palmer, where we've been doing it for a few years now. We have focused on capturing the response. So obviously, patient outcomes are directly related to what's done, the level of familiarity with clinical outcomes, and getting the right resources to the patient. But we haven't sort of individually looked at patient outcomes, which I'd love to do. But I think there are a couple of articles in the resources that I'm going to make available that look specifically at patient outcomes. Okay, let's see. I'm trying to see what other areas are asking questions here. And I think we're going to probably stop soon because we're a few minutes over. So what are the best ways to document or show ROI for in-situ simulation? So I think some of the things that I was just talking about, you need to figure out a way to capture what's happening during real events. And ideally you have that prior to and after you institute your program, but also on a continuing basis, right? So again, you can do sort of formal budgetary processes where you can look at how much it's costing the organization to put these on. In reality, the cost is not usually that high, but looking at what the cost is, and then looking at outcomes related to if you've identified latent safety threats, if you've and address them, of course, systems issues. That's an area of ROI. Again, often organizations get really invested in this when something bad happens. Ideally, it's not in that order, and we're a little more preventive. But sometimes it's in response to that. And then, like I can tell you, we haven't had any deaths since we implemented this program, and it started with a death, right? And so, so that's an obvious place for ROI, and it started with a death where there was a big, medical liability payout. So, those are definite ways that are concrete that you can show, but there's a lot of other ways. If you can capture the latent safety threats and that they've been addressed, or near misses, and then look at the actual responses themselves, have the teams document what happens, and then and debrief, and then look at what's happening, what's not happening, how the patients do. You can actually track this. And this has been done in some areas. Like when rapid response teams were first implemented, the number of codes drastically reduced in the organizations that did this, and they were able to show it. So we can do this. And then I'll do one last one, because again, we're a bit over here. What kind of metrics do we report out? So I think I've talked a little bit about this, but I like to put things in structured areas. It makes it easier for discussion. It also makes it easier for looking at things. And by the way, I do not do 3 checklists by myself when I do this. Obviously, that's not a feasible thing. So this is where there is a little bit of investment. I always need to have another person that's looking at at least one other area. I usually have someone do the teamwork components because I can usually manage both the clinical management and the systems response. But sometimes I get lucky and I have 3 of us and everybody's focused on the different area, and that's ideal, but not always possible. So you do the best you can with what you have available to you. But the metrics that we report out, I actually look at each of these areas for each of the simulated events that we do, and I give them back, what the scenario was, where we did it, what went well with regards to each of the areas, and then where the opportunities for improvement are, and then if we have any recommendations for systems, equipment, location, response. The last one that we did, we had the unit secretaries come. And then they saw that it was a mannequin and there's a bunch of new folks. So again, we do this, you get everybody on the same page, and then there's new providers. So they were new to it and they walked away. So after we did the debriefing with the healthcare team, I took a few minutes and I debriefed them. And I talked about, okay, so if this is a real case, you need to stay because they may need you to call somebody, and we went over what are the things that should happen and what their role is in these kinds of situations. So all of those things get reported back to the hospital, which is again a bit of a burden on the simulation educator, but really I think leads to more long-term improvement. And of course, Joint Commission, if you work for an organization that has accreditation, they can actually keep this together as showing it's a quality improvement program, it's a patient safety program, and they can actually show this to those accrediting organizations as these are the things that they're doing. So all of those are opportunity. Okay, so I'm going to stop there. I know there's a lot more questions. I will try to answer any big pressing questions after the fact if Laerdal makes that available to me. So thank you so much to all of you for participating today. Please go forth and simulate. And if you're thinking about getting started, figure out what you do have available to you and get started, because often that'll start the domino effect of getting folks invested in you being able to build a program. So thank you all so much, and look forward to seeing you out in the simulation world.